I'm speaking today with Dr. David Chan from the Stanford Medical School. David is visiting the Monieson Center for Business Research and Healthcare as part of our Healthcare Economics series. David has just given us a wonderful paper on emergency departments, and I'm very anxious to ask David, what were you trying to discover in your research?
It really traces back to some random events in my training. So what happened was I trained to be a doctor, going to medical school, then residency first, and then went into a PhD in economics because I'm kind of started from an interest in health policy. But as a result of that sequence, I became very interested in what happens within organizations in healthcare, what determines differences in productivity, and particularly what determines physician behavior that rolls up to these differences in productivity. And I thought that the emergency department was an excellent setting to study this because of the richness of the data, the frequency of the visits, and just kind of the multitude of interactions between physicians and each other, as well as physicians and patients, physicians and nurses.
Now, in reading your paper, I must say I found myself really thinking about shift work in a way that I never had before. I'm very familiar with emergency room procedures and with shift work per se, but it never really occurred to me that doctors had the kind of motivations that they would have toward ending a shift. And you explore this. Tell me a little bit about what experiment you set up and what you discovered.
I thought that the emergency department was a great setting to study this because you have a lot of natural experiments that use variation in differences when shifts end. So you can kind of control for the time of the day. You also have differences in the length of the shift, so you can control for the amount of time that you've worked and separate that from the amount of time that you have until the end of the shift. But as people have decreased the hours that physicians in training or residents spend in the hospital consecutively, they're now running into problems of how do you staff a number of patients that you have appropriately, and also more importantly, the issues of handing off patients that involve communicating what you know about a patient to another doctor, and there invariably will be a loss of information there. So what this research does is to kind of map out yet another issue where when you have ending shifts or transition times between shifts, you have yet another potential distortion in what a physician will do if that physician has a preference that either the patient doesn't care about or the hospital doesn't care about, which is to go home in a timely manner.
Yeah, so in an 8-hour shift, for example, what's the difference between a doctor's behavior in hour 2 of the shift and say something close to the end of the shift?
So what happens if you see a patient in hour 2? The average patient length of stay is about 5 hours. So there's not, 5 hours or less. So there's not much danger in you staying past the end of your shift. If you do see a patient kind of in the second to last hour or the last hour of your shift, you basically kind of have to hustle if you want to go home right at the end of shift. Now, in practice, doctors never go home at the end of their shift. The end of the shift is actually kind of a rule for when you should stop seeing patients, stop accepting new patients. And in practice, doctors really stay 2 to 3 hours past the end of their shift. But if they see a patient in the last hour or the second to last hour, then there's really kind of the chance that that patient might make them stay longer than they were expecting. And you've got the standard reason that they would rather be at home than at work, but you've got other reasons such as you would want certain hours. You have plans for when you go home. Dinner is waiting, or you've got to pick up your kids from school, and those are kind of important things to know about the modern work environment, and particularly in healthcare.
So what happens to doctor decision-making in the last hour, did you find?
So doctors kind of have 2 margins which they can kind of exercise discretion in. The first margin is whether they accept a new patient, and that's the most easily observable margin. Does a doctor pick up a new patient that comes to his location near the end of shift? The second margin is much more complicated and is much more difficult to observe, and that is the doctor can change patient care for patients that he is seeing at the end of his shift. And by changing patient care, that means changing the inputs to patient care, meaning the time that he spends on patients, as well as the orders, the formal tests and orders that he makes use of in patient care. And I find that these inputs can either be substitutes or complements, but I find that what doctors do is that they substitute by spending less time on these patients, because time is more costly near the end of their shift, but they spend more on tests. And ultimately, what a doctor in the emergency room is doing is he's deciding whether to send a patient home or to admit that patient as an inpatient. And as they become less certain of the information they're gathering with the time and orders they're doing for these patients, they're more likely to admit these patients.
So just thinking of what kind of flexibility a hospital might have in terms of structuring its shifts, what does this imply for it? Does it imply that the hospital should have more overlap between shifts, or are there other structures that it might employ to better manage the consequences of these?
Right. So yeah, I think that's a great question. So I think there are two general things that the hospital could do. One is, how does it structure its shifts? And that includes overlap between shifts. So on the one hand, kind of the mechanical view would be, if overlap is redundant and you wouldn't need two doctors when one doctor could certainly see a patient. But if you've got these behavioral distortions near the end of shifts, what I find is that overlap allows you to offload patients from a doctor who is ending a shift and reduce that distortion in patient care. The second thing is, when you have a shift structure, how do you assign patients? So do you kind of give incentives for physicians to see more patients or not? And these incentives, certainly for doctors who are paid fee for service, can certainly be there financially, where even though you're ending a shift, you might see that patient and do a few things that wouldn't take time, and then get the credit for seeing that patient, but you optimally should not see that patient. But there are other things that, from a hospital's point of view, you should appreciate, and that is that there are huge social incentives as well in the hospital. So even when there are no financial incentives for doctors to see patients, oftentimes you have incentives for doctors to see patients, because if they don't see those patients, the next peer who's coming on board will have to see that work. So from kind of that peer group standpoint, the doctor is helping his peer, but perhaps hurting the healthcare system, the hospital, and maybe even delivering worse patient care.
Do you think anything has changed over the years in terms of the way doctors perceive their roles that would have implications for this? And I'm just as you described the kind of shift orientation
Yes.
in the ED department, it almost sounds commercial in a
Yes,
way that
absolutely.
the historic mission of healthcare really held the doctor's role to be different. Has just the change of the world
Absolutely.
brought
No,
this about?
that's a great question. I think what I tried to motivate my talk by is that healthcare has changed dramatically over the last 3 or 4 decades. It used to be that you would have a single doctor who is your primary care doctor, see you both as an outpatient, then follow you into the hospital and take responsibility for you regardless of where you were. And obviously, my dad was actually this type of doctor. He never went on vacation. And so now you've got changing workforce where you can have a family with both doctors, and you have a value to not always being on call. But you also have, perhaps as fundamentally, a change in how healthcare, what healthcare means. You've got a proliferation of new technologies, things that you can do for diseases that are very time sensitive, as well as new process measures. So for a given patient coming in with the same diagnosis now versus in 1970 with a heart attack, there are probably 100 times more things that you should do for that patient within a short time period. So timeliness and complexity of care are things that have just changed by leaps and bounds over the last few decades, and that's changed the nature of care. So as a result, you see care being delivered by organizations of doctors and nurses and other healthcare providers. And just by the complexity of it, there's a greater emphasis on kind of scheduling, because there's, that's the way to kind of manage this now complex problem that involves many providers and complex care.
You know, as I was reading the paper, you had me thinking about whether the proximity to the end of the shift in a way reflected some kind of, not moral failing on the part of the doctors, but just a lack of commitment to those historic values. But then I thought, well, you know, the young families and the two working couples, and maybe it's just...
Yeah. So I think in economics, an unfortunate word we have, I like this word, but an unfortunate word is the word moral hazard.
Moral hazard, yeah.
And it's, you know, the history of the word is interesting, but I think, it communicates a precise idea that, you know, as long as you have a difference in objectives between a principal and an agent, and as long as you have information that the agent has but the principal doesn't have, you could have a setting where the agent or the worker is doing things that the principal would not like to do. But that doesn't mean anybody is morally decrepit here or has a moral failing. It's just that we need to recognize these differences in objectives, and in some cases, the policy, the organizational setting itself leads to these differences in objectives. If schedules didn't exist, then you wouldn't have this kind of wedge in behavior where a doctor wants to go home. If instead the culture was that doctors lived in the hospitals, which was the case 40 years ago, there was no wedge because doctors weren't going anywhere. And so it's not a case that those doctors were better morally. It was just that the organizational setting has changed because the nature of healthcare delivery has changed.
Well, David, it's been absolutely great having you here. Thank you very much. I've been speaking today with Dr. David Chan from the Stanford Medical School.